I'm going to discuss the role of surface sensors in our management of total knee replacement. My conflicts in this case include consulting for consensus that makes one of these types of devices. The use of patient-reported outcome measures, that is PROMs, has been critical to the success of total knee arthroplasty. It's helped us evaluate new implants, materials, and surgical techniques. It's been essential to the development of perioperative protocols, and it's had a major impact on the decisions that we use regarding treatment and care of patients. The problem, among others, with PROMs is that they're virtually useless in the early postoperative period, and they give very little objective functional information about how a total knee is actually performing. Moreover, the PROMs are difficult to administer, they're time-consuming, and in general, the compliance rate, particularly if your patients are trying to use them, is relatively low. And they don't measure patient satisfaction. So surface sensors are emerging to allow objective measurements of specific functional outcomes. They allow the capture of daily range of motion, they track movement in real time, and they track the recovery process, and in addition, can alert us to sudden, perhaps adverse events. There are some requirements, therefore, that we need to think about with regard to the use of surface sensors. Are they safe? Are they comfortable? Can they be used by all patient populations? Are they durable? Are they waterproof? And can they be used and worn at all times? Are they easy to apply? Is the software and the hardware that are parts of these devices user-friendly? Are they HIPAA compliant? That's a real issue. Are they patient and provider efficient? That is it easy for patients to use them, and is it easy for providers to understand the data that they're getting? And is the information useful and accurate? Surface sensors can measure a number of things. They can measure the range of motion, they can measure the duration of exercises that patients are carrying out, the frequency with which these exercises are being done, the daily activity, for example, the number of steps the patients are taking during the day, how much they're walking during the day. They allow patients to record the level of pain in relationship to these activities, and if they want, that patients can also enter PROMs. And they detect sudden events. If someone suddenly loses a range of motion, both the patient and the provider are aware of that in real time. So I want to just walk through the way in which these sensors are used. I've had experience with one of them, the TracPatch, but there'll be a number that emerge. You can apply these sensors in the operating room at the beginning, at the end of the case, or you can apply them in the early postoperative period. You can then measure them. You have to register these devices, and then you can measure them starting with the initial postoperative period. Patients then go home with them, and then they can carry out their own exercise program. They can monitor their exercise program. They can monitor the activities that they do, and these activities are then transmitted to the provider, who can see these results in real time, both for that day and the cumulative experience of the patient over the treatment time rhythm. You can also begin to start correlating things like range of motion with other patient characteristics. For example, you can correlate range of motion with gender, as you can see there on the left. Or you could correlate a range of motion with BMI, if that was something interesting to you. And you can see that while patients with large BMIs seem to start a little higher, they progress a little slower than patients with slightly lower BMIs, at least in our initial cut of this information. So the use of surface sensors, along with conventional patient-reported outcomes, I think will make possible new advances in joint arthroplasty. By being objective, they'll allow the evaluation of new implants and materials and surgical techniques, many of which are discussed at this meeting, but have very little validation because the outcome measurement tools that we use are not sensitive to these things, for example, to the robotics. They will be essential to the development of perioperative protocols that will allow us to differentiate patients based on the way in which they perform both preoperatively and postoperatively. And they'll have a major impact on the decisions that arthroplasty surgeons make regarding the treatment and care